Hi, my name is Phil Longman. I'm the author of a book that came out in 2007 called Best Care Anywhere, Why VA Healthcare is Better Than Yours. It's a book I never expected to write. It came out of an assignment that Forbes Magazine gave me several years ago to go out and find for them whoever it might be that was the Jack Welsh of Health Care. Jack Welsh, you might remember, was the take-charge CEO of General Electric in the 1990s. He'd been on the cover of Fortune many times. And the editors there thought, well, there must be somebody in healthcare who's sort of the equivalent, and we ought to introduce the nation to him or her. And so I accepted this assignment with great passion and interest, and part of the reason was personal, because several years before I had lost my wife, Robin, to breast cancer. And what I saw of the U.S. healthcare system during that ordeal had awakened me to the fact that there were deep problems of quality, coordination of care, medical errors. So I set out to find who is the Jack Welsh of healthcare, who was doing it right, and really wanting to know. And after a short while, I came in contact with a rather small group at that time of medical researchers, many of them centered at Dartmouth University, also Dr. Donald Berwick at Harvard, who I went to see and sat on his knee and listened for a day. And what they were telling me was a message that I could not really believe when asked who's the Jack Welsh of healthcare. But I took it upon myself to read their studies that they pointed me to, and these were studies of the quality of healthcare. New efforts were being made at the time to develop metrics of what is quality in healthcare, looking at both inputs and outputs. And time again, this single institution was showing up at the top of these quality metrics. So I went to visit this institution. And what I saw there was unlike anything I'd ever seen in an American hospital, and I'd seen a lot of hospitals. The big difference was that doctors made their rounds pushing little trays with laptop computers on them, and so did nurses. It's not uncommon today to go to a doctor's office and have them break out a laptop, but these were different laptops. These were laptops where, with a flick of a switch, you could see a patient's complete medical record going back to 1986, or some cases into the 70s. These were laptops in which the practice of medicine was changed at many levels. For example, I observed that when a medication was given to a patient, the patient had a identification band with a barcode. The nurse had the same, and the med itself had a barcode. And there was a ritual of first scanning the med, scanning the patient, scanning the nurse. If it was the wrong med at the wrong time, the wrong person, the wrong dose, the computer stopped that. I knew that was a big deal, and we all know it now because the Institute of Medicine has, in a recent study, told us that the average American experiences one medication error every day he or she is in the hospital. Hundreds of thousands of Americans die from these kind of medication errors, and this kind of procedure, simple as it might seem, saves tremendous numbers of lives. In the course of doing my research on the book, the favorite part for me, and I think for most readers, is the chapter on the so-called Hardhats. I was, of course, curious to find out where this fantastic world-class VistA medical health care system came from. And it turned out that it was through a collection of very colorful and committed frontline employees of the VA who, starting in the late 1970s, had more or less on their own, against central office dictates, developed a whole new model of healthcare, in some cases using Wang word processors, which they repurposed to their needs in order to disguise from central office that they were doing this kind of work. It got very nasty at times, I came to find out. Many people were fired. There were edicts that no personal computers on VA property. Mini computers were confiscated and put in warehouses. There were OMB investigations. And yet this small band, sometimes known as the Underground Railroad, persevered because they had a common vision, because they knew that they weren't going to get the support they needed from central office, and out of sheer idealism and commitment, they gradually cobbled together some 18,000 different programs that came to be known as VistA. It's an inspiration, and it's also a lesson, because it shows the extreme importance of creating software that involves the actual user. VistA was a program, it's not really an exaggeration to say, created by doctors and clinicians for doctors and clinicians. And so even though some parts of it might have been crude, not as eloquently written by our standards, it had almost immediate buy-in from the folks that use it. And that's very important, because we've seen elsewhere in the healthcare system, time and time again, a hospital will buy some commercial system, install it, send a memo to the doctors telling them this is the new way we're doing things around here, and the doctors rebel. I think it was at Cedars-Sinai in Los Angeles that ripped out a brand new system just because it had no buy-in from the doctors. So this collaborative, horizontal pattern of software development where the users are involved with the production of the software is vital. And I think it's part of a hard hat culture that's vital to preserve at today's VA and to try and instill in other settings. VistA is not simply a piece of software. It is itself a process, both in the actual writing of the code, but also in interpreting how to use it. And perhaps the most impressive and overlooked facet of it is the opportunities these digital records offer for the development of real evidence-based medicine. Collectively, they form a database of outcomes that can allow researchers to go in after the fact and notice things like, gee, when we prescribe Vioxx, people tend to die in disproportionate numbers. And you can do this without a great clinical trial. You can do it with very little money, and you can do it fast, which is one of the reasons the VA was among the first to notice the great dangers of a drug like Vioxx. This is the great new frontier in American medicine to me. As a person that comes from outside of medicine, but has come to learn more and more about it, I'm just constantly struck, time and again, about how little science there actually is in the delivery and protocols of healthcare. That more often than not, no one's ever bothered to look to see whether one device is better than another, whether one surgery is more effective than, say, massage therapy. The studies aren't there, or what studies are there are funded by drug companies or otherwise inadequate. This is a whole new way of advancing the science of medicine by looking at reality at a population level rather than just a molecular level. And it turns out that you can learn much more for less money and with much greater effect, oftentimes, most times, by concentrating on population level health outcomes, which is what this little band of brothers back in the 1970s, working with their Tandy computers and their DEC mini computers have brought us, and I salute them, and I'm very happy to be here tonight to celebrate their accomplishments. It's very important that policymakers and people in the private sector who are evaluating VistA and what it has to offer realize that it comes from and is part of a process involving the people who use it, and that there's a great danger in trying to centralize and bureaucratize the process of health IT. It takes a while to get your mind around it. When you have a free-form, open source, collaborative process, sometimes bad stuff happens. Sometimes somebody takes a laptop home and it gets stolen. You know, sometimes when you're in front of a congressional committee and they ask you, what exactly are you doing on health IT, it's hard to say because there's not exactly anybody in charge. It's free form. But we have to learn to trust our frontline employees and to take advantage of the idealism and the competence that they have, and to allow them to make mistakes.